The medic's hands trembled as he knelt beside the shattered body of a 19-year-old infantryman on the blood-soaked sand of Omaha Beach. Through the chaos of machine gun fire and the screams of dying men, he reached for the small syringe hanging from his belt, a glass tube no larger than a toothpaste container, filled with a substance that had relieved human suffering for thousands of years. With a practiced motion born of desperate necessity, he jabbed the needle through the soldier's uniform and into his thigh, squeezing a half grain of morphine tartrate into the traumatized tissue. Within minutes, the young man's agonized screams would fade to ragged breathing. His body granted a chemical reprieve from the devastating reality of his wounds. This scene, I'd repeated countless thousands of times across every theater of the Second World War, represented one of the most critical yet overlooked elements of modern combat medicine. While historians debate strategy and tactics, the small morphine syringe quietly revolutionized battlefield survival, transforming the treatment of combat trauma and saving lives that would have otherwise been lost to the merciless arithmetic of shock and pain. The story of morphine's dominance on the World War II battlefield begins decades earlier. In the research laboratories and pharmaceutical houses of the early 20th century, morphine itself had been isolated from opium in 1804 by German pharmacist Friedrich Serturner, who named the alkaloid after Morpheus, the Greek god of dreams. By the American Civil War, morphine had already proven its value in treating battlefield casualties, though its administration remained crude and dosing inconsistent. The development that would transform morphine into the battlefield standard came in 1940, when Squibb Pharmaceuticals, working under contract with the United States Army Medical Department, perfected the morphine syringe. This ingenious device combined a collapsible tube similar to a toothpaste container with an attached needle and protective cap. Preloaded with a standardized dose of morphine tartrate dissolved in sterile water, the syringe represented a triumph of practical engineering over pharmaceutical tradition, packaging a controlled narcotic in a form that could be administered by minimally trained personnel under the worst possible conditions. And the manufacturing of these life-saving devices took place primarily at Squibb's facilities in New Brunswick, New Jersey, where pharmaceutical workers, many of them women replacing men sent to fight overseas, worked around the clock to meet military demand. The process began with morphine base, itself derived from opium imported under strict government control from Turkey and India, the two nations whose poppy cultivation supplied the Allied war effort. The morphine base underwent chemical conversion to morphine tartrate, a salt form chosen for its superior stability and water solubility. In temperature-controlled mixing rooms, pharmacists prepared solutions containing precisely 1/2 grain, approximately 32 milligrams, of morphine tartrate in distilled water with small amounts of preservatives to prevent bacterial contamination. This concentration had been carefully calculated by Army physicians to provide effective analgesia for severe trauma while minimizing the risk of respiratory depression in shocked patients. The filling operation demanded meticulous attention to sterility and precision. Workers in white coats and surgical masks operated semi-automated filling lines where each small tube received its measured dose before mechanical crimpers sealed the aluminum containers. Attached needles, manufactured to exacting specifications for sharpness and durability, were protected by removable wire loops that kept them sterile until use. Each completed syringe underwent inspection, with quality control technicians checking for proper fill volume, seal integrity, and needle condition. Batches received lot numbers for traceability, and samples underwent potency testing to ensure the morphine concentration remained within acceptable limits. The finished syringes moved to packaging areas where they were placed in small cardboard boxes, 12 to a box, then crated for shipment to military depots. From New Brunswick, These small tubes of chemical mercy traveled by rail and ship to staging areas across the United States, then aboard transport vessels bound for North Africa, Europe, and the Pacific. The logistics of morphine distribution represented a challenge nearly as complex as its manufacture. The United States military medical system in World War II operated on an unprecedented scale, supporting millions of service members deployed across the multiple continents and thousands of miles of ocean.
We're out of morphine.
Medical supply sergeants tracked morphine stocks with the same attention
We
given
need
to
more
ammunition and rations, knowing that shortages could mean the difference between controlled treatment and unmanageable suffering. Each combat medic received an initial issue of morphine syrettes, typically 10 to 12 units, carried in specially designed pouches on their field equipment. Battalion aid stations and field hospitals maintained larger stocks, while evacuation hospitals and general hospitals farther from the front lines kept substantial reserves. The cold chain requirements for many medications did not apply to morphine syrettes, which remained stable at normal temperatures. Though excessive heat could accelerate degradation and extreme cold could cause the solution to freeze and crack the glass tubes. The training of medics in morphine administration evolved throughout the war as medical officers accumulated experience with combat casualties. In training camps across America, young men selected for medical duty learned the basics of trauma care, including when and how to administer morphine. The instruction emphasized several critical points. First, morphine was indicated for severe pain from traumatic injuries, particularly those involving broken bones, severe burns, and penetrating wounds. Second, medics learned to avoid morphine in cases of head injury, where the drug's effects on consciousness and pupil size could mask signs of brain trauma, and in abdominal wounds, where the decrease in intestinal motility might worsen internal injuries. Third, they drilled on the proper technique. Remove the wire loop protecting the needle, squeeze the tube to expel air, insert the needle at a shallow angle into the muscle of the thigh or upper arm, and squeeze the tube completely to deliver the full dose. Finally, and perhaps most importantly, medics learned to mark morphine administration by attaching the empty syrette to the casualty's collar or by marking an M on the soldier's forehead with the victim's blood or dirt, preventing accidental overdoses when multiple caregivers treated the same patient during evacuation. The experience of receiving morphine on the battlefield varied dramatically depending on the nature of the wound and the speed of treatment. For a soldier with a shattered femur from an artillery fragment, the initial injury produced pain so overwhelming that rational thought became impossible. The body's response to severe trauma included a cascade of physiological reactions: massive release of stress hormones, rapid heartbeat, elevated blood pressure followed by potential shock as blood loss continued, and muscle tension that could worsen fractures and accelerate bleeding. When the medic's needle penetrated the muscle and morphine entered the bloodstream, the alkaloid molecules traveled rapidly to the brain and spinal cord, where they bound to opioid receptors that regulated pain perception and emotional response. Within 10 to 15 minutes, the patient would typically report a dramatic reduction in pain intensity, though complete elimination of pain was neither expected nor desired, as some sensation helped prevent further injury during movement and transport. The psychological effects of morphine proved nearly as important as its analgesic properties in battlefield medicine. Soldiers who received morphine often described a sense of detachment from their injuries, an emotional distance that allowed them to endure evacuation and initial treatment without the terror and panic that could complicate medical care. This anxiolytic effect helped prevent psychological shock, a condition that could prove as deadly as physical trauma in severely wounded men. Combat veterans who survived serious wounds frequently recalled their morphine injection as a moment of transition when the chaos and agony of injury gave way to a manageable a almost dreamlike state that carried them through the golden hour of trauma care. The development of morphine doctrine in different theaters of war reflected varying tactical and environmental challenges. In the European theater, where established supply lines and relatively short evacuation distances characterized operations after the initial invasions, medics generally had adequate morphine supplies and could administer the drug liberally to seriously wounded men. The Bocage, fighting in Normandy, with its close quarters combat and high casualty rates, saw heavy morphine consumption as medics worked frantically to stabilize wounded men before evacuation through the narrow lanes to battalion aid stations. In Italy, where mountainous terrain and limited roads complicated medical evacuation, morphine became even more critical, keeping casualties stable during prolonged transport over rough ground. The Pacific Theater presented unique challenges for morphine use and supply. The tropical heat and humidity threatened morphine stability, requiring careful storage and frequent rotation of stocks. Island hopping campaigns meant that medical supplies had to be staged aboard ships and moved ashore under fire, with morphine among the highest priority items. The brutal nature of Pacific combat, with its high rates of severe burns from flamethrowers and crushing injuries from jungle fighting, demanded generous morphine use. Marine Corps medics, known as corpsmen, became legendary for their courage in reaching wounded men under fire and for their skill in administering morphine under impossible conditions. The Surrette's design proved ideal for Pacific combat, as corpsmen could carry multiple units in the wet, muddy conditions where glass ampules would have broken and traditional injection equipment would have failed. The North African and Mediterranean campaigns introduced lessons about morphine use in extreme heat and prolonged combat operations. Medical officers noted that soldiers fighting in desert conditions, already stressed by dehydration and heat exhaustion, sometimes showed enhanced sensitivity to morphine side effects, particularly respiratory depression. This observation led to recommendations for slightly reduced initial doses in severely dehydrated casualties, with additional morphine given as needed once fluid resuscitation began. The desert campaigns also highlighted the importance of protecting morphine stocks from excessive heat. Nikbar, as Surrettes stored in direct sunlight or in vehicles exposed to the desert sun, could reach temperatures that accelerated drug degradation. The German military's approach to battlefield analgesia differed from the American system in significant ways, though morphine remained central to their combat medicine as well. German pharmaceutical companies, particularly Merck in Darmstadt, produced morphine hydrochloride in both ampule and tablet forms. German medics carried morphine ampules that required a separate syringe for injection, a system that provided more flexibility in dosing, but demanded more skill and equipment than the American Surette. The Wehrmacht Medical Service also issued morphine-scopolamine combinations for particularly severe injuries, as German physicians believed the addition of scopolamine, an anticholinergic drug that produced amnesia and sedation, enhanced pain relief, and reduced psychological trauma. Whether this combination truly improved outcomes remained debatable, but it reflected the German emphasis on pharmaceutical intervention in combat medicine. The Japanese military's limited use of morphine and other analgesics revealed both supply constraints and cultural factors that shaped their medical practice. Japan's limited pharmaceutical industry and restricted access to opium sources, combined with military doctrine that emphasized endurance of suffering as a warrior virtue, meant that Japanese soldiers received far less pain medication than their American or German counterparts. Captured Japanese medical supplies typically contained minimal stocks of narcotics, and Allied intelligence officers noted that Japanese military medical manuals devoted little attention to pain management compared to American or British field manuals. This disparity in analgesic availability contributed to the high mortality rates among wounded Japanese soldiers. as men suffering from severe pain and shock often died from complications that adequate morphine treatment might have prevented. The immediate post-injection period for morphine-treated casualties involved careful monitoring by medics and aid station personnel for signs of adverse reactions. While morphine's safety profile generally proved excellent when used for its intended purpose, several complications could occur. Respiratory depression, a slowing of breathing rate that could progress to respiratory failure, represented the most serious risk, particularly in patients who had also sustained chest injuries or who were in severe shock with compromised circulation. Medics learned to monitor breathing rates and to have injectable stimulants available for cases where morphine appeared to suppress respiration dangerously. Nausea and vomiting occurred frequently enough that medical personnel expected it and positioned casualties to prevent aspiration of stomach contents. Itching, particularly around the injection site and face, affected many patients, but rarely required treatment beyond reassurance. The longer-term challenge of morphine use in military medicine emerged in the evacuation hospitals and general hospitals, where seriously wounded men received extended treatment. These soldiers who required multiple operations and prolonged hospitalization for severe injuries often needed repeated morphine doses for pain control, creating the potential for physical dependence and addiction. Army medical officers recognized this risk and implemented protocols for gradually reducing morphine doses as healing progressed, substituting less potent analgesics when appropriate. The medical literature from the immediate post-war period contains numerous studies examining addiction rates among wounded veterans, generally concluding that medically supervised morphine use for legitimate pain, even when prolonged, rarely led to problematic addiction in the absence of other risk factors. This finding, controversial at the time given prevailing fears about narcotic addiction, helped establish modern pain management principles that distinguish between physical dependence, an expected physiological response to regular opioid use, and addiction, a complex behavioral disorder. The role of morphine in enabling complex battlefield surgical procedures deserves recognition alongside its use for initial trauma care. At battalion aid stations and mobile surgical hospitals, Army surgeons performed emergency operations under conditions that would have been impossible without effective analgesia. Morphine, often combined with small amounts of inhaled anesthetics when available, allowed surgeons to debride wounds, set fractures, and perform amputations on men who could not be evacuated to rear area hospitals. The development of forward surgical units, small teams of surgeons and nurses who operated within miles of the front lines, depended absolutely on the availability of morphine and other analgesics to keep patients stable during and after emergency surgery. These units, forerunners of the mobile Army surgical hospitals that would become famous in later wars, saved countless lives by providing definitive surgical care before shock and infection could prove fatal. The story of morphine in World War II cannot ignore the darker aspects of its use and the ethical questions it raised. Medical officers sometimes faced agonizing decisions about morphine allocation when supplies ran short during intense fighting. Should morphine be reserved for salvageable casualties who might survive with treatment? Or should it be used to ease the suffering of mortally wounded men whose deaths were inevitable? Different medical officers answered this question differently, and the psychological burden of such decisions haunted many military physicians long after the war ended. Similarly, the question of whether to give large morphine doses to hopelessly wounded soldiers to hasten death and end suffering represented an ethical boundary that some medics reportedly crossed, though documentation remains scarce and controversial. The legacy of World War II morphine use extends far beyond the immediate relief it provided to millions of wounded soldiers. The Sarette design influenced post-war development of pre-filled injectable medications for emergency use, leading eventually to the auto-injectors used today for everything from epinephrine for allergic reactions to antidotes for nerve agent poisoning. The massive scale of morphine production and distribution during the war contributed to advances in pharmaceutical manufacturing quality control and in the logistics of maintaining medical supply chains under combat conditions. Perhaps most significantly, the successful use of morphine by minimally trained medics helped establish the principle that effective pain management was not a luxury reserved for rear-echelon hospitals, but an essential component of trauma care that should begin at the point of injury. This insight, paid for with the suffering of millions of wounded men and the dedication of thousands of combat medics who risked their lives to provide care under fire, it transformed military medicine and ultimately influenced civilian emergency medical services as well. The small glass sirette, carried in the pouches of young medics from Normandy to Okinawa, represented more than a delivery system for a powerful drug. It embodied a commitment to the fundamental dignity of the wounded warrior, a promise that even in the mechanized horror of modern warfare, there remained a place for the ancient medical imperative to relieve suffering and preserve life.